Welcome to AETCM. Shall I present the case? Today, I'll be presenting a case of a 21-year-old male who presented to a ER with alleged history of deliberate self-harm by ingestion of Paraquat 2 days prior to the presentation to our ER. So he was initially taken to the outside hospital and then referred to our hospital. On arrival on 10-second assessment, airway was patent. There was no pooling of saliva. Breathing part, air entry was bilaterally equal with a respiratory rate of 22 per minute, and on auscultation, bilateral crepitations were present. On circulation, BP was 135/85 mmHg with a pulse rate of 100 per minute. Disability wise, patient had a GCS of 15 out of 15 and pupils were equal and reactive to the light. On exposure, patient was afebrile and had a GRBS of 112 milligrams per deciliter. So at this point of time, we had taken an ABG and it was showing a pH of 7.3 with a PCO2 level of 31, bicarbonate of 17.7, PO2 of 83, and it also showed a creatinine value of 9.1 and bilirubin 6.3. We had also done a CBC CRP point of care which showed total counts of 8.5 with a platelet of 1,25,000, HB of 14.7 and CRP of 54. We had also initially taken HB was 14.7. We had also taken an ECG to rule out the presence of any arrhythmias, but there was no arrhythmias. So at this point of
basically
time,
21-year-old male with alleged history of consumption of Paraquat 2 days prior to presentation in Amrita. Right now, patient's respiratory rate is a bit high, saturation is but normal, and on auscultation, like primary survey, the B part, you heard some crepitations in his chest. So that is expected. If it's Paraquat, we expect pulmonary issues. And then once you completed your primary survey, you did ABG, which showed deranged RFT as well as LFT. And INR was?
Point of care INR was not done, sir. Creat and bilirubin we got from the ABG.
So the Paraquat, the normal toxicity, what we expect is basically involvement of lungs, liver, as well as kidney. And then some, if its consumption is usually, if it is orally, you'll expect some oral ulcerations, burns, kind of things, because it's a caustic kind of, it's a herbicide, right? Widely available herbicide in India. So it's very toxic to humans and almost mortalities, if RFT, everything is already involved, mortality is almost 100% guarantee.
So at this point of time, we had also collected samples for toxicology. So we had taken the blood and the urine sample for sending the toxicology for Paraquat. So it is we can only get the qualitative test. So we had also collected the samples and sent for toxicology. So then coming to the sample history in this patient, 21-year-old patient with no known comorbidities came with alleged history of deliberate self-harm by ingestion of Paraquat, that is around 100 ml mixed with 1 glass of water 2 days prior to presentation to our ER.
How much?
100 ml.
100 ml of?
100 ml of Paraquat was mixed with 1 glass of water, and then he had ingested it.
What percentage of?
It was 20%.
20%, 100 ml mixed in
1 glass of water.
1 glass of water, and he drank it. It's lethal dose. One mouthful itself is 30 ml, of 20 to 24% Paraquat itself is lethal. Okay.
So he had consumed a lethal dose, and he had presented to our ER 2 days after the ingestion. So basically, after the ingestion, he developed multiple episodes of vomiting, and the vomitus was greenish in color. So the bystanders
immediately after consumption,
he started to vomit.
That's the history.
Yes, sir. So the vomitus was greenish in color. So the bystanders had a suspicion, and then later he relieved to his parents that he had taken the poison, and then within 45 minutes of ingestion of the poison, he was taken to an outside hospital, and from there he was given gastric lavage.
Why did he consume this thing, Paraquat? Does he have any mental problem?
No, basically he had some personal issues, relationship issues, and then he had taken it. So in the outside hospital he was given gastric.
What time did he consume?
Morning 8:30 a.m. was the time when he consumed it.
In empty stomach?
Yeah, in empty stomach. And then following that, within 45 minutes he had reached the outside hospital, and from there gastric lavage was given. And then following...
Gastric lavage, is it indicated here?
No, usually in paraquat poisoning, since we take it as caustic acid itself, we don't give gastric lavage, but you can insert a Ryle's tube and aspirate the contents.
Yes, just aspiration is enough. Don't do a gastric lavage, it's contraindicated. What about activated charcoal?
Yeah, if the presentation is within 1 hour, then activated charcoal 1 gram, that is maximum of 50 you can give. 1 gram per kg.
Maximum 50.
50 you can give.
Was it given in this
No,
case?
in this case it was not given. So then from that hospital, patient was referred to the medical college. And on...
Nothing else was given?
No, only this was given. Gastric lavage was done and then referred to medical college. On arrival to the medical college...
Are we supposed to give oxygen in this case?
No. Paraquat poisoning, we can't give oxygen unless the saturation falls down below 90%. It is contraindicated because in paraquat poisoning, basically the paraquat gets concentrated in the cells, and then it triggers a redox cycling between the paraquat and the paraquat radicals. As a result, superoxide radical will be formed. It is a reactive oxygen species, and it will produce more of other free radicals. These free radicals will cause injury to the tissues. So basically there will be depletion of NADPH also. As a result, it will lead to the mitochondrial dysfunction, necrosis and apoptosis of the cells. So usually we don't give oxygen until the saturation falls below 90. Our target will be always 88 to 92. So he was taken to medical college, and from there 1 session of hemoperfusion was done for the patient, and there he was kept on NPO and Ryle's tube was inserted.
When was it initiated, hemoperfusion?
It was initiated by evening. Basically the guidelines tell that as fast as possible hemoperfusion.
Within 4 hours,
4 hours is
after consumption of paraquat you should initiate hemoperfusion. It should last for around 3 to 4 hours.
3 to 4 hours. But there was a delay in hemoperfusion, and it happened in the evening. By evening, 1 session was done, and then he was kept on NPO for the next 24 hours. And then...
so overall everything got delayed. Initially itself, even if they presented within 45 minutes, but they had done a gastric lavage, which shouldn't have been done at that point, and they didn't administer activated charcoal also. And then they referred him to some other hospital, and they did a charcoal hemoperfusion, but it was very much delayed. And in hospital, he was kept NPO, and then he was started on methylpred injection. And during that hospital... In that hospital.
So during that hospital stay, his initial creatinine values were 0.8.
Methylpred injection, how are we supposed to give?
Usually we give high dose steroids in case of paraquat poisoning. If we are giving dexamethasone, then we'll have to give 8 mg. We'll be giving every 6th hourly.
8 mg, 8 hourly, 8 hourly, right?
No, 6th hourly also we can give.
Okay, so TID or QID for 3 days?
Yeah, you can give up to 3 to 4 weeks also. High dose steroids can be given. But the complication is that the patient might develop infections due to the...
What is the rationale behind giving?
Patient goes into fibrosis. Lung fibrosis can happen. So in order to prevent the lung fibrosis, we give high dose steroids. So here patient was started on methylprednisolone, and also injection cyclophosphamide also was given to the patient. Because in paraquat poisoning there are studies which show that immunosuppression can help. So cyclophosphamide injection also was given from the outside hospital. And then
I don't think it is given in up-to-date, right?
Yes, it is given. We can give. There are some studies which show benefit.
But they have like some studies.
That's all. It's not part of a guideline. And then during there, the initial creatinine level was 0.8 milligram per deciliter, and over the 2 days, it had worsened to 7.6 milligram per deciliter.
What?
Creatinine levels. From 0.8, it became
so the rapid rise in
7.6.
creatinine itself is a poor
Prognosis.
indicates poor prognosis.
And then his LFTs also from the outside hospital started to get deranged. So initially the LFTs, OTPTs were normal. At the end of 2 days, it came to the level of 150. And then slowly on the second day evening, he started to develop difficulty in swallowing the feeds. So he was complaining of odonophagia and dysphagia. And then the patient was referred.
Oral ulcerations were there?
Oral ulcerations was there. So then he was referred to a hospital for further management.
Fluids, was he started on some fluids?
Yeah, he was started on fluids, supportive fluids was there, ongoing 100 ml per hour was there. And then referred to
any
a hospital.
dyselectrolytemia?
No, dyselectrolytemia was not there as such. So on arrival to a hospital.
But feed, what was feed given? RT feed or
No,
something?
first 24 hours he was on NPO. Riles tube was also inserted. Then following that, on the second day, patient had removed the Riles tube by himself. And then Riles tube was not inserted. And on the second day evening, he started to have odonophagia and dysphagia. Hence that whole day, he didn't take any feeds. So coming to our ER, he was complaining of severe odonophagia and dysphagia. And then in our ER, initially we had given a nephro consultation in view of the deranged RFTs, and then we had planned for a hemoperfusion. And then
no acidosis.
Initial ABG values were like pH of 7.369, not severe acidosis, but bicarb was 17.7. And
Lactate?
Lactate was 1.6. And then we had also started the patient on N-acetylcysteine infusion, vitamin E and vitamin C supplementations. So according to the recent studies, N-acetylcysteine is an antioxidant. So it can have a good effect.
How much of dose will you give?
If the presentation is within 1 to 4 hours, you can give 150 mg per kg per hour dose, and later you can give 300 mg per kg.
Is it written like that? Where is it given?
Infusions can be given. In up-to-date, according to the up-to-date, it has been written that higher doses than what we give in paracetamol toxicity can be given here. Because in Paraquat also there is an NADPH depletion. So if you supplement with N-acetylcysteine.
Isn't it 300 mg per kg per day? That isn't it the dose?
Yes,
Just confirm it.
high dose can be given as written. So we had also started the patient on N-acetyl infusion, vitamin E supplements and vitamin C supplements. And then we had also started continued DEXA 8 mg Q6H. So at this point of time, since the patient was complaining of odonophagia and dysphagia, and also patient didn't have a Riles tube, we wanted to proceed with an gastromedicine consultation so that we could do a endoscopy and insert the Riles tube, and also we can look for the ulcerations. So we had planned for this. Meanwhile, the patient started to cough. And then patient started to have collection of secretions in the mouth, and there was pooling of saliva. Even though we had done multiple times suctioning, there was severe pooling of saliva and patient started to gurgle. So at this time, patient started to desaturate. So initially from 96% of saturation, patient slowly started to desaturate. Up to 90% we had not provided with supplemental oxygen. But once the saturation fall behind 90%, we just connected the patient to supplemental oxygen. And at this point of time, we had conveyed the bystanders the grave prognosis, and we had also spoken about.
He aspirated basically.
Since there was ulceration, severe odonophagia, he was not able to swallow the saliva, and the saliva was getting collected in the mouth. Even though we were suctioning it out, patient was coughing severely and gurgling started.
Okay.
So since the airway was threatened, we had also spoken to the bystanders the need of intubation, and then we went ahead with the mechanical intubation in this patient. So in view of impending respiratory arrest, as patient was having continuous desaturation, and in view of threatened airway, we had gone ahead with the intubation, and we were intubated the patient. Even after the intubation, we had followed lung protective ventilation strategy in this patient. So we had aimed for low
But
tidal
here it's all
volume.
fibrosis is going to
Yeah.
happen, right? Because of Paraquat.
Paraquat. Usually the processes lungs will go into fibrosis. So here we kept low tidal volume and optimal PEEP.
Paraquat is going to act wherever there is increased oxygen. Wherever there is increased
Increased blood flow and
increased blood flow.
So usually it acts on your lungs, liver, kidney. Usually it doesn't affect your brain because it doesn't cross the blood-brain barrier.
Once oxygen is delivered, so lungs is again going towards.
It's a vicious cycle.
Yeah.
So as our FiO2 increases, again more of free radicals
So now
will
there
be
is no way
produced.
out.
Yeah.
It's already.
Once the patient starts to desaturate and once we supplement with O2, the patient gets more and more deteriorates. So here we had intubated since we didn't have any other way. Since patient severe gurgling, pulling, everything was there, we had to intubate the patient. And post intubation, initially with an 80% of FiO2, patient was maintaining the saturation, but over hours patient again started to desaturate, and then we had to keep the patient on 100% FiO2. And post 6 hours, patient initially the BP was stable. Post 6 hours, patient went into hypotension, and then initially since already IVC it was not severely collapsing, we started the patient on inotropes, and initially we had started him on injection noradrenaline, and then due to refractory hypotension we had to start on multiple inotropic supports, and then that at that point of time we had taken the blood gas analysis.
Why did the BP fall?
Because usually in paraquat poisoning, most of the cases mortality causes this lung involvement and hypotension. So they will go into severe acidosis also.
No, is it like hypovolemic, obstructive, distributive, or cardiogenic? This shock. This patient has gone into hypotension and shock, right?
Yes, sir.
Is it hypovolemic? Is it because of less fluid, or is it obstructive? It's not obstructive anyway.
Not obstructive.
Distributive sepsis was there? Any infection?
So his CRP was 54. So patient had a mild
Maybe like he
infection.
deteriorated again, went into sepsis, gradually went into sepsis and became septic shock. Cardiogenic shock, or how is the echo?
Echo, sir, we had done, it was a fair LV. So there was no dysfunction as such.
Only septic shock is left, no?
Yes, sir. So here patient went into hypotension, and then multiple inotropic supports were started for him, and then even then hypotension.
By this time the ABG would have worsened to severe.
So we had done a
lactic acidosis.
repeat blood gas analysis, and then patient went into severe lactic acidosis. So his pH started to deteriorate, and then
So then hypoperfusion to various organs, and then again it's going to deteriorate.
And within 15 hours of the presentation to an ER, we couldn't save him. Mortality had happened.
It's almost 100% mortality with Paraquat.
So coming to the paraquat poisoning is a
And there is
byproduct.
this thing also, one nomogram is also there. Paraquat. Foot tap nomogram. Something of that. Nomogram is there beyond after 4 hours after consumption of, just like paracetamol, Romac-Matthew nomogram, that's a nomogram. After consumption of this thing, you mark the level. If it is above the line, means the prognosis is bad. Okay. Continue.
So paraquat is a bipyridine compound, and it is a very commonly available herbicide, which is very less expensive. So it is one of the most commonly used toxin. And as we have already discussed, the mechanism is that once you ingest it, it is a highly high volume distribution toxin. So it gets distributed all throughout your organs and the blood. So there will be free radical production.
Any protein bound.
Yeah, it is protein bound. That is why we go ahead with the hemoperfusion as such. So if the toxin what we take is a water soluble, then we can go ahead with the hemodialysis. And if it is a protein bound, we can go ahead with the charcoal hemoperfusion can be done. And in cases where there is severe renal function derangement, we can go ahead with both together. So simultaneously hemoperfusion and hemodialysis can also be taken. So here in this
which other cases hemoperfusion is done? Which other cases? Not Paraquat.
The dialysable drugs can be taken up.
Hemoperfusion, basically. Causing sepsis, cytokines and all, no, you're removing.
HLH can
Yeah.
be, HLH case can be taken up. The most common dialyzable toxins are the INH can be done. There is a code for that. That is I stumbled. Which are the dialyzable toxin? I stumbled.
Mnemonic for.
It is a mnemonic to remember the toxins. So I is INH, and then S stands for salicylate.
This is for dialysable.
Dialysable drugs. S stands for salicylate. T stands for theophylline, U is uremia, M is methanol, B is barbiturates, L is lithium, E is ethylene glycol, and D is dabigatran. So these are the most common dialysable drugs. So here we have done hemoperfusion since it is protein bound.
Once we do hemoperfusion, even other drugs will be taken away, like some cardiac drugs and barbiturates and all these things will also be taken off. Removed along with the Paraquat. The patient is already a known CAD and all these beta blockers and also things will be removed. Okay.
Paraquat is basically a bipyridine component, and as we have discussed, it will cause a free radical production. So when a patient comes to our ER, primary importance is in airway, because mostly affected is the lungs. So we have to take care of the airway, and we have to make sure that if the oxygenation goes below 90% only, we'll have to connect the patient to O2. Unnecessary supplementation of oxygen will do more harm to the patient. And then once the patient deteriorates, his saturations fell down 90%, then there is an indication for supplementing oxygen. Then the other things that we have to look is the lethal dose of Paraquat. So it is 30 ml, that is a mouthful or two of 20 to 24% is the lethal dose.
That we have already discussed.
Yes, and the clinical features with what it will be presenting is mostly patient will have a painful mouth and there will be ulcerations and burns. Patient will have vomiting, abdominal pain, etc. And then if you look the oral cavity, there can be erythema, ulcers, and coated tongue can also be there. Patient will be complaining of dysphagia, odonophagia, etc. Then in ER we'll have to look for the respiratory rate and the pulse oximeter. Then we'll also have to look for the BP and the heart rate of the patient, because early death may result from the progressive refractory hypotension. Then chest wise we have to look for the whether any tachypnea or dyspnea is there for the patient, because usually Paraquat will lead to the alveolitis. So that has to be taken care. And abdominal wise, you have to look for whether there is any abdominal pain, vomiting. So these are the things that we'll look. And then coming to the evaluation and diagnostic part, we'll usually look for the RFTs, LFTs, because it causes modes. We have to look for the RFT, LFT. We have to repeat the blood gas analysis, and we have to check for the lactate levels in the patient. Then you can also proceed with the chest X-rays of the patient, because it will show features of the alveolitis. So chest X-ray has to be taken. Then toxicology samples can be sent. Basically, we can only do the qualitative analysis. So urine, blood samples can be sent for the qualitative analysis up to 100 hours from the ingestion. If lethal dose has been taken up to 100 hours, it will show positive. So until 100 hours, we can send for the toxicology levels.
Is it when are we supposed to take blood and urine samples after
that is in patients with severe poisoning. You can take from the ingestion time up to 100 hours. It has been documented.
Immediately after that, immediately after ingestion you get.
Yeah, you will get in your aspirate, gastric aspirate. It will show positive first.
That is there. The blood and urine.
Usually blood becomes positive after the period of redistribution.
That's what I told. After 4 hours.
4 to 6
hours you can draw the blood samples and send.
You can do. Then urine Paraquat also can be sent within the 12 hours of poisoning. It can be sent, and then
usually it is excreted via urine, right?
Yeah,
Paraquat.
it is excreted via urine. And then coming to the management part, if the patient is presenting within 1 hour, you can give the activated charcoal, that is 1 gram per kg, maximum
just
of
like
50
all poisons
can be given. As we have already told, gastric lavage is contraindicated, only aspiration has to be done. Then if it is topical or topical inhalation, then you have to decontaminate the whole body. You have to give the wash and decontaminate the body. Then since there is no antidote in this toxin, the primarily specific treatment is your extracorporeal extracorporeal therapy, that is our hemoperfusion we have to do. Then other things are all adjuvants to our therapy, that is you can give your anti-inflammatory and immunosuppressive therapy. As we have discussed, we'll give steroids.
Steroids you have mentioned.
Then we can also give this immunosuppressive therapy of a combination of cyclophosphamide and glucocorticoid. Both of them can be given. Then the adjuvant is the antioxidant therapy. In that we will be giving acetylcysteine, higher doses than that used for paracetamol poisoning can be given. Vitamin C, vitamin E, deferoxamine, etc. can be given in the patient. Then
so basically charcoal hemoperfusion, steroids and acetylcysteine, and then all supportive
things only can be given. And then if the ongoing management, you have to look for any electrolyte imbalances, you have to look for any derangement in renal function, blood lactates, etc. can be done. And if the patient survives, if the patient has taken very minimal amount and patient survives, the complication is that after 4 to 8 weeks, patient can develop lung fibrosis and derangement in the renal functions. So that is regarding the Paraquat poisoning.
And that differential diagnosis, if history is not there, that X-ray and all
shows alveolitis.
Can resemble this thing, PCP, pneumonia.
PCP pneumonia.
That X-ray and all these findings and all. No? But the whole thing depends on a proper history taking. When if you get a history that the patient has consumed Paraquat, you can start treatment earlier, and you want to know whether it's a toxic dose or not, and at what time he consumed, because after, depending on that only, the treatment can be modified. Within 4 hours it has to be initiated. Okay, anything more?
Thank you, sir.